Hi, everybody. My name is Nora Redman. I'm an occupational therapist working in the pediatric setting. And today we're going to talk a little bit about occupational therapy in the NICU setting and also touch on a little bit of feeding in the NICU. So, just before we start, just to give you guys a little bit of background about myself and kind of where my career has been, I graduated from Elizabethtown College in 2013 with a Bachelor's of Science in Health and Occupation. And then I went on to finish with my Master's of Science in Occupational Therapy in 2014. I took a little bit of like a break year, just having to wait to take my boards, and I traveled a little bit and had some fun before jumping into the working world. But I've been working since 2015, all in pediatric settings. I started out in pediatric outpatient at TheraPlay, if anybody's heard of it before, for field work or just lives in the Philadelphia area. I moved on to the school setting for a little bit. It was both an elementary school and a high school, so I got a little bit of both. I did a little bit of early intervention through the school system, and then since then, I've been working in the hospital setting, doing both inpatient and outpatient therapy, and that's where I started to get my experience in the NICU. I'm pretty involved in a lot of different memberships, and I try to keep current with certifications, and I'm always looking for new things to do just to keep my career exciting. I'm an AOTA member, which I recommend to all of you getting out of school. They have really great resources. It's amazing time going to conference and just kind of meeting people. You find that the OT world is vast, but it's also a really small world, and you tend to run into the same people in different jobs and at conference. So it's really fun to have those kind of connections, both friendships and in the professional setting. I'm also a NANT member, which is the National Association of Neonatal Therapy. They also have some really great resources, especially if you get into the NICU system and you just need peers who can help support you and kind of bounce ideas off of and providing resources. And they also have a conference every year that you can attend. I recently, in the last year, became certified in neonatal touch and infant massage. So that's a really exciting thing that I'm having a really fun time implementing into my practice with patients and also teaching caregivers. And then I'm also a member of the Phoenix Burn Society. I work in my previous job, I just started a new job at Children's Hospital of Philadelphia, but I was working at St. Christopher's Hospital, which is a smaller community hospital, and we were a burn center, so I did a lot of work with burns. Sorry, some technical difficulties here. Okay, so to start out, I just want to talk a little bit about the levels of the NICU. This was something that I really didn't know a ton about until I got into the NICU setting and started working as an OT there and taking courses and really kind of diving into what it meant to be a NICU and kind of the qualifications. So, a lot of you have probably heard of a level 1 NICU without even realizing it. Those are considered like the well baby, newborn nursery. That's where the normal, quote unquote, babies who are healthy, full term, they don't really need too much care. They are often referred to as the well baby unit. You find near term babies or full term babies who have minimal medical care requirements and are discharged home pretty quickly after they are born. So that's kind of the basic of the basic. A level 2 NICU is more advanced care. So those are for babies who are born after 32 weeks who are recovering from more serious health problems. This is often referred to as a specialty care unit. These facilities are required to have pediatric hospitalists, neonatologists, and a neonatal nurse practitioner on board, in addition to all of the providers that are in the level 1. So the typical doctors, nurses. They typically provide care for infants born at 32 weeks or older weighing more than or equal to 1,500 grams who are moderately ill with problems that are expected to resolve pretty quickly and are not anticipated to need subspecialty care on an urgent basis. So these are the less urgent, less involved babies who need a little bit of extra support compared to the level one healthy full term babies, but they can still kind of survive without too much extra involvement. Um, the level two will often stabilize infants who are born before 32 weeks gestation until they can transfer them to a higher level NICU, like a level three or a level four, where they can provide that kind of care. A level three is typically more specialized care. These are for the sicker babies, so the ones who need a little more support than the advanced care and the basic care. This can mean they need more life support, whether it's respiratory or more involved, like subspecialties of doctors. They provide comprehensive care for infants born at all gestational ages and birth. So there's no kind of guideline for specifics of that, as the others were 1,500 grams and over or 32 weeks and over. The level three can take kind of any of the babies at any level of gestation. They offer more of the subspecialists, including surgical specialists, anesthesiologists, and ophthalmologists. So they're able to do some of those more involved surgeries that babies in the NICU might come into the world needing. And we'll touch a little later on in another part of our lecture about common diagnoses you might see, so it'll make a little bit more sense when we get to that of kind of where those diagnoses fit in the NICU levels. A level three can also provide a lot of respiratory support, whether it's high setting, just like more involved oxygen, or whether it needs to be a ventilator or nitric oxide. Kind of the possibilities are endless with that. And they're also able to provide advanced imaging with interpretation on site, so and on a more urgent basis. So whether it's an MRI or an echo, and they can be read pretty immediately to get the ball rolling of whether there are surgeries needed or other kind of more involved interventions needed at that time. And then a level four NICU is the highest level of care. Sometimes I find some conflicting information with this in different courses that I've gone to. Sometimes they'll call them like a level 3B or a 4 or 4A and B, but typically hospitals go by level 4, and those are the most complex patients, the most involved care. So they can provide surgical repair of more complex congenital and acquired conditions. This might be some of like the more involved brain injuries that you might see, or heart conditions that require surgery. Some of the more gastro issues, including necrotizing and enterocolitis, and things like that babies need more immediate response to and can't really wait to have those surgeries. They also have more medical subspecialists, including surgical subspecialists and anesthesiologists on site as well. They can also arrange transport and provide outreach education to the families and communities. And then probably the most distinguishable difference in a level 4 NICU is that they can provide ECMO support. So for those of you who haven't heard of what ECMO is, I always have to read it off the page because it's a tongue twister. Extracorporeal membrane oxygenation. So I will say, my first experience with ECMO was terrifying. Usually you can kind of feel how the pressure, the intensity of how serious it is when a baby is going on ECMO. I've also seen adults and older children on ECMO, but usually when it's a baby, it's pretty intense. The environment is pretty scary, but it's something that you get used to working with. As an OT, our role during ECMO, so ECMO, basically the baby's blood is they have a site in their jugular and it's being filtered out into this machine where it's getting oxygenated and then going back into their body and kind of doing the work for their body. Um, but there's a lot of restrictions on moving the baby. You have to be really careful with positioning. So, as an OT in the NICU that I worked in, we were really involved in we were lucky and had physical therapy and occupational therapy, which isn't always the case. So we worked really closely with PT and they kind of took on the role of the positioning during ECMO. So the baby has to be on its back, which really is limiting a lot of positions for us. So just working with making the baby comfortable, making sure that they're kind of kept in midline with all of their limbs so they're not kind of out here and extended and retracted. We want to keep them nice and tucked in because these babies, if you think about them being in the womb, they're usually in what we call physiological flexion. So flex towards midline, it's a comfort position for them. So then when you're adding all of these stressors of ECMO with lines and tubes, and then you're also having them positioned out like this, it's just a really not a great environment for the baby to be in, and it can cause more stress than it needs to. So PT would kind of take the role of working with the nursing and the medical team to position the baby. And then as OTs, often these babies will be very swollen, or they might be a little, they could be either like hypertonic or hypotonic, depending on the situation. So we would go in and make little baby hand splints, which I don't have a picture of. I wish I did. But basically, we would just make these little tiny resting hand splints out of, typically for a more full-term baby, we would use the typical splinting material. But for these babies, since they are more fragile, we would use foam that you can kind of mold and then just really soft strap to just keep their hand in a nice neutral position, because a baby could be on ECMO for less than 24 hours or they could be on ECMO for 10 days. It's kind of all kind of up to that baby's body and how they respond to it. So we really want to try to give them the best chance at keeping their typical movement patterns and positioning as we can, because it's kind of out of their control. So it's our job to help with that. So where I work now, I'm at CHOP. We are a level 4 NICU. I just started there, so I haven't been in their NICU too much, but going forward, I'll kind of talk about my experience in the NICU at St. Christopher's Hospital, which was also a level 4 NICU.